ABC Pharma, Artificial Intelligence Doctor. Pacing-Induced Cardiomyopathy PICM. Last updated. October 9th, 2025. Category: Cardiac Electrophysiology. At a glance, what is it? A decline in left ventricular function caused by chronic right ventricular RV pacing related to synchrony. Typical definition: drop in LVEF by greater than or equal to 10% to less than 50% with an RV pacing burdened, typically greater than or equal to 20 to 40%, with no other clear cause. Mechanism: unnatural activation sequence, LBBB-like, electrical/mechanical desynchrony, adverse LV remodeling, key risks: high RV pacing percent, apical lead position, wide-paced QRS, pre-existing borderline LVEF, long pacing duration. Prevention: minimize unnecessary RV pacing. Consider physiologic pacing, his bundle or LBBAP, or CRT in appropriate patients. Treatment: upgrade to physiologic pacing, HBP/LEAP, or CRT. Guideline-directed HF therapy. Address alternative causes. Why it happens. Standard RV apical pacing produces a left bundle branch block-like activation. The ventricles contract out of sync, reducing pump efficiency and, over time, remodeling the left ventricle. This can manifest as a progressive fall in left ventricular ejection fraction, LVEF, and heart failure symptoms. How clinicians define PICM. LVEF decline. Greater than or equal to 10% absolute reduction to less than 50% from pre-implant baseline. Pacing burden. Usually greater than or equal to 20 to 40% ventricular pacing over time. Exclusion. No alternative explanation. Ischemia, myocarditis, tachy-mediated, valvular, etc. Note: exact cutoffs vary by study and guideline. Use clinical judgment and serial imaging. Who is at higher risk: high cumulative RV pacing, especially greater than 40%, right ventricular apical pacing versus septal/outflow pacing. Wide-paced QRS duration. Pre-existing borderline LV function, older age, longer pacing duration. Symptoms to watch: exertional dyspnea, fatigue, reduced exercise tolerance. Peripheral edema, weight gain, orthopnea/PND. Decline in 6-minute walk distance or functional class. Diagnosis and monitoring: baseline and follow-up pre-implant echo to document baseline LVEF. Repeat echo at 6 to 12 months and with symptoms. Device checks for pacing percent and paced QRS width. Look for alternatives: ischemia evaluation when appropriate. Rate/rhythm issues: AF with RVR, PVC burden. Valvular disease, myocarditis, infiltrative causes. Prevention and treatment: minimize RV pacing with device algorithms when atrioventricular conduction is intermittently intact. Physiologic pacing to restore near-normal activation. His bundle pacing, HBP. Left bundle branch area pacing, LBEAP. Cardiac resynchronization therapy, CRT, for appropriate candidates, e.g., LVEF less than or equal to 35% with desynchrony. Guideline-directed medical therapy for heart failure. Reassess with echocardiography 3 to 6 months after a pacing strategy change to document reverse remodeling. Leadless pacemakers. Special notes. Single-chamber leadless devices, e.g., VR systems, typically pace the RV 100% of the time. Most patients do well. However, a subset may develop PICM over years. If LV function declines with high RV pacing burden and no other cause, consider an upgrade path, e.g., LBBAP or CRT, to restore synchrony. When to consider an upgrade: LVEF drop greater than or equal to 10% to less than 50% from baseline with high RV pacing. Worsening HF symptoms attributable to desynchrony. Wide-paced QRS despite optimization.